we'll do in this lecture, we'll actually start getting into multiple things with terminology and some other issues, and start getting into the meat of the matter with athletic training. Some of the things you're more interested in. Say, for instance, this x-ray we have up here right now. With this x-ray, when you first look at it, it's like, wow, I see something's really wrong there. But we'll start putting some terminology to it and some descriptors to that. And many of these slideshows for when we get to each joint and say knee injury, ankle injury, lower leg injury, you'll see some types of x-rays with some descriptive terminology we'll go over now. First thing with terminology, we'll look at a sprain versus a strain. With a sprain, S-P-R-A-I-N, the first one we're looking at here, is injury to ligaments. So ligaments connect bone to bone, and when we sprain, we injure them. When we classify that as a first, second, or third degree sprain. So a lot of people may say, when we think knee, they blew out their knee. When we sprained our knee, now is a first, second, or third degree. First degree sprain is, we'll look at three things mainly when we think sprain. Number one, pain. Number two, laxity. Number three, endpoint. We'll add some other things that are common, but when we do a test, we want to know, is there laxity, is there an endpoint, and is there pain? So when we test for a sprain, we want to test that ACL ligament in the knee. For a first degree sprain, there is no laxity. So it's tight, it's not loose. It doesn't move any more than the opposite knee. We always do a bilateral comparison to the other side. So if my left knee's hurt, I compare it to my right knee to know if it's normal or not. So one of the things when we get a history and a SOAP note, when we start documentation, is have you ever hurt your other knee before? We need to know if we're comparing to something that's normal for that person or not. So first degree injury, there may be some pain, generally not much if any swelling, not much if any discoloration. They have function. We don't see any deformity. The function may be limited, but they can do stuff. There's not a laxity. There's a good endpoint. When I'm talking about endpoint, if you look at me here, it's when you take your finger and pull on it, sudden stop, or when you straighten your elbow out real fast. Get that sudden snap stop right there at the end of your elbow. That's an endpoint. With your elbow, it's a bony endpoint. With the ligament, that ligament is a static stabilizer and should stop at a certain point. So always look for that. In a second degree, you'll have usually some swelling, more pain, usually some laxity, but there is an endpoint, but it's looser than the other side. So when we stress that ligament, it moves further, allows that joint to move further than the opposite side. The other thing is there is an endpoint, usually have a lot of swelling, they lose function, may not completely lose function, but lose most of their function, may have some discoloration, and be very uncomfortable. A third degree sprain is complete disruption. It's torn in two, it's ruptured. So there's not an endpoint. It's very lax, so you test the left knee and it moves a whole lot more than the right knee if the left knee is injured. You have a lot of swelling most of the time. It's very painful. There can be deformity, and they don't want to use it, they'll guard it. They don't want to use it at all. They a lot of times don't want you to touch it. It's very painful. The second thing is a strain. A strain is injury to tendon, so think of ST for tendon or muscle. Tendon connects muscle to bone. Muscle gives the force for movement. So a strain can be first, second, or third degree. Again, third degree being the worst, or mild, moderate, and severe. Mild first degree, moderate second degree, severe third degree. Usually most people will still use first, second, third degree. First degree, it's painful. They tweaked it, quote unquote. They can still function with it. There's not minimal swelling, usually minimal discoloration, if any. It feels normal. If you feel the texture of the muscle under the skin, right to left. So if you strain, what people call it a pulled hamstring muscle. So if you have a first degree strain, which is a pull, then it feels the same on the left hamstring muscle as it does the right hamstring muscle. Second degree, you feel some defect in it. It feels like a knot. You may feel disruption in it. It feels like a little divot. There's some loss of function. loss of strength. There is some black and blue probably because of bleeding. There is a lot of swelling. It's warm to the touch because it'll increase in temperature to allow it to swell. 3rd degree is complete rupture, complete torn in half. People call it tore my muscle. I didn't pull it, I tore it. That's what they mean is a 3rd degree sprain. So now on, everything is a sprain or a strain, depending on what it's to, and it's 1st, 2nd, or 3rd degree. We'll come back to that with each joint, and you'll need to carry that to each joint and from exam to exam. The next thing is, what's the difference between a broken bone and a cracked bone? A lot of misused, interchanged things used to mean the same thing. Any disruption in bone, we call it a fracture. If it's disrupted, it's fractured. With a fracture, we're going to start giving it classifications now. The first one we'll do is it open? Or another name for open is compound. And what that means is it sticking out of the skin. When you fractured the bone, did it push its way through the skin? If it is, it's an open fracture. Or is it closed? Another name for closed is simple fracture. It's not breaking through the skin. So you can't see the bone sticking out of the skin. Just because it's a simple fracture, meaning a closed fracture, does not mean it's not life-threatening. If somebody has a simple fracture of their femur, their thigh bone, there is a large artery that sits right beside it, femoral artery. They can sever that artery and bleed to death. So all this does is describe, is it sticking out of the skin, open or compound, or is it not sticking out of the skin, closed or simple? You can get the same thing with a dislocation. When we talk about dislocation, it can be sticking out of the skin, open dislocation or compound. It can be closed or simple dislocation. And then once we do that, we want to label by appearance. This blue line should probably be better with oblique. When you look at the way it looks. Because it really just, how does it appear when you put it on X-ray? If you look at this, you see kind of that jagged edge right here. It looks kind of straight across right here. So you could say oblique or transverse. A spiral fracture is one that spirals up. So it kind of goes around the bone and spirals up it. And can be very hard to see on X-ray. An oblique is a diagonal fracture. So it looks like this. Transverse is straight across. It's a horizontal fracture straight through the bone. Comminuted or impacted, two other terms, means there's several little pieces of the bone. It depends on whether they're close together or spread out, whether it's comminuted or impacted. Avulsion, think of a bone chip. Pulled a little piece of bone off. You sprain their ankle, the ligament pulls away from the bone and pulls a little bone chip off with it. That's an avulsion fracture. Or you fall down and hit your elbow real hard and chip a little piece of bone off. That's an avulsion fracture. And then stress fracture. So the constant pounding, the overuse, and you develop a little crack in the bone. That's a stress fracture. Dislocation versus subluxation. Going back to broken bone versus the fractures, signs and symptoms of a fracture. Obvious deformity, discoloration, swelling, disuse, loss of function, multiple things, very similar to sprain and strain. But with fracture, anytime someone is point tender on a bone, always think fracture until you're proven otherwise. And that's with diagnostic testing. But many times with a stress fracture, sometimes even a spiral fracture, it's not seen on X-ray. You go to clinical suspicion, meaning if you push on that bone and it's really tender, we're going to treat it as a fracture until we can actually prove it otherwise. So we'll mobilize it, we'll put them on crutches for a couple of weeks, then we come back and re-X-ray and see if we see anything. And a lot of times it heals. As it heals, you'll see a bright line on the X-ray. Anything black on an X-ray is air. You should see a nice continuous portion of the bone. You see air. And obviously you see the deformity where it should be connected together here. But you see black space in between, that's air. So we want to make sure nothing's going on before we say there's not a stress fracture. It's just quote-unquote shin splints. Dislocation versus subluxation. You dislocate a joint. You do not fracture joints. You don't break an ankle. You don't break an elbow. You don't fracture an ankle. You dislocate joints. The articulation comes apart from each other, where they move against each other and roll on each other. So a dislocation, it comes completely out of joint. It may reduce itself spontaneously. We call it spontaneous reduction. It goes back in by itself. Or we send them to the emergency room and allow a physician to, they order an x-ray, then they will put it back in themselves. They reduce it, the physician does. Subluxation, it comes partially out of joint. Signs and symptoms of a dislocation: obvious deformity, loss of function, swelling, disuse, discoloration. Subluxation, very similar. Generally, you may have some function, very little, limited, very weak function, or they may lose the function completely, either way. So dislocation or subluxation. A fracture or dislocation always needs to be referred. First time sprain needs to be referred, especially if they're an adolescent, because they're still growing. You've got growth plates to worry about. So always be concerned with the adolescent. And to cause one of these, any of the above, dislocation, a subluxation, a fracture, a sprain, or a strain, we have to have a mechanism of injury. What caused the injury? Direct force. I got hit by a baseball bat when the batter threw it and didn't drop it. Or I got beamed with a baseball. I'd hop and took a baseball hit. I got hit. Somebody hit me in a collision on the football field. I fell and hit the turf. Direct force. You can also have an indirect force. I fall and catch myself on an outstretched arm and I injure my elbow. The force hit my wrist, but the force translated. Nothing happened to my wrist. I didn't fracture my forearm, but my elbow got injured. That's an indirect force to the elbow. Overuse, improper mechanics, all of these are mechanisms of injury. We can go on and on and list the mechanisms of injury. Many things can cause an injury. We'll classify sports. This is kind of a hodgepodge, a weird place to put this, but we classify sports. As an athletic trainer, how do I know where to be? If I'm the only athletic trainer for a school, where should I be if 3 sports are going on? If football is out there, and cross country is out there, and soccer is out there, where do I need to be? You need to be at the highest risk sport. In your book, you'll find classifications of sport: contact or collision. And you'll need to list some that are contact or collision. Obviously, football, and some of the others are obvious. Limited contact and non-contact. So classification of sport gives us one way of figuring out where we need to be. Think of it as a tiering system, so to speak. And it may be limited to non-contact from your pre-participation physical or your screening. Saying, wait a minute, due to this reason, you can only do non-contact sports. Think of field events and track, maybe swimming, those types of things. Next is, once we have an injury, this is what we call tissue response to injury, or the body's response to injury. What happens when an injury happens? So the first thing is we have an initial injury. That's the first thing here, initial injury. Hopefully you've printed this out. You have it in front of you. So as we're doing this, you can kind of look at it if you can't see the smaller print on any of this. So we have initial injury. The first response from the body is we want vasoconstriction. So the vessels at that area constrict. They get smaller. That's what we want. Unfortunately, the vasoconstriction is very short-lived, and then we vasodilate. When we vasodilate, the vessels get bigger. Think of your eyes. The pupils dilate, they get bigger. They constrict, they get smaller. Same thing with blood vessels. When they constrict, when they dilate and get larger, they also become more permeable, so stuff can get out. The swelling, the liquid, the water, we call it exudate, the white blood cells, all that can get out to the injury. It's the body's natural protection mechanism to cause the joint to swell, kind of self-splitting, so to speak. But in athletics, if it swells, it also adds pressure. And mechanical pressure, and with the other chemical mediators that's in the bloodstream that's released there, it heightens the sense of pain and causes pain because of the swelling. So if we control the swelling, we can control pain. But once we get vasodilation, once it swells, then we get into this thing we call pain spasm cycle. So we have swelling, it heightens the sense of pain, the swelling causes pain causes spasm, spasm causes pain. And it's a cycle. You stay in this cycle until something breaks it. That's where something comes in. What do we do to break this cycle? That's what we say, get ice on them. Hopefully we've gotten ice on them up here. As soon as the injury, as close as possible to injury happening, get ice on them and get it elevated. And we'll talk a little bit more about elevation here in a second. And if they're in the pain spasm cycle, then they don't want to use the muscles around that area because it causes pain. If we don't use it over time, we lose it. The old adage, if you don't use it, you lose it. We get atrophy. If we get muscle atrophy, the muscles get smaller, and it puts us into rehab. We have to get that muscle back to full strength. We have to get full range of motion. We have to get the swelling out. Multiple things we'll look at in rehab. The first we'll look at in rehab, the things we'll call second intention healing. If we don't treat it right, it won't heal right. If we don't treat it correctly, it won't heal correctly. We call it second intention healing. With second intention healing, you're more likely to re-injure that again. Whether it's joint, muscle, bone, whatever it is, you're more likely to have another injury to that same thing because we didn't treat it properly, didn't heal properly, and you're set up for another injury. What we want is over here on the other side. In rehab, we treat it properly, we split it properly, we do everything like we're supposed to, and it heals like it's supposed to, and it's a lot less likely to re-injure. So least likely to re-injure if you have first intention healing. With least likely to re-injure, doesn't mean they're never going to have another injury. This means that they new injury and not aggravation of the same one. Aggravation of the same one is second intention because we didn't do things like we should. We put them out there too early, whatever it may have been. So tissue response to injury. Initial injury, then we get vasoconstriction, very short term. Then immediate vasodilation. And the vasodilation, chemical mediators make the vessels more permeable, meaning things can get out of the vessels and into the joints and cause swelling or around the muscle, wherever it's at. And once it causes swelling, we get a lot of pressure. And with those chemical mediators, we feel a lot of pain. When we start feeling a lot of pain with pressure, we get spasm, muscle spasm. With spasm, we get pain. With pain, we get spasm. We're in this cycle. And then because of this cycle, we don't use whatever it is. We get muscle atrophy, and then we have to go into rehab. And with rehab, our goal is first intention healing. It heals like it's supposed to, and we're least likely to re-injure. If we get into this track of second intention healing, we didn't treat it properly, it doesn't heal properly, and you're more likely to re-injure it. It's not the way we want to go. Along with the body's response, we also have a psychological response to injury. You really need to pay attention to this. We don't talk about it a whole lot in this class. Those that are going into athletic training will talk about it a whole lot more. Unfortunately, even medical doctors probably don't get enough of it. Psychologists and psychiatrists probably have, obviously that's what they're trained in, is this area. And one thing we'll look at, we call it a Kubler-Ross stages. A lot of people call it Kubler-Ross stages of death and dying or death and grieving. But they will go through these stages with an injury, a season-ending injury, or excuse me, a career-ending injury. Either one, they'll go through those. We use the acronym DABDA. With DABDA, you can have denial, anger, bargaining, depression, and acceptance. Everyone will go through these stages. A death of a teammate, a season-ending injury, a career-ending injury, they're going to go through them. It may not even be season-ending or career-ending. It may be going to miss half the season. Or miss the second half of the season, even makes it worse because it's toward the end of the season they can't help their team get to where they want to be. So the first, they're in denial. It's not my ACL. I didn't blow my knee out. It's got to be something else. Let's get a second opinion. We get the second opinion. Same thing. MRI shows the same thing. And then they're angry. They're angry at everybody. They have anger. They're angry at you. They're angry at the coach. They're angry at the teammates. They're angry at everything in life in general. They're just angry. Everybody will go through. Sometimes they go through the first two stages very quickly. Sometimes it takes days or sometimes weeks. Then they get into bargaining. Just tape it or put the brace on it. Let me try it. If it hurts or it feels like it's going to give out, it feels unstable, I'll stop. I promise I'll stop. Don't let them talk you into that. They will bargain and try to let them get out there. They'll try to gain you're okay, so go ahead and try it. Let's see if you can try it. Don't do that. You've got to go back and explain things to them. Depression. Make sure you know someone is depressed. Be able to recognize signs and symptoms of depression. Withdrawal, social withdrawal, eating change habits, whether they eat a whole lot or don't eat at all. Grades dropping, don't go to class, quit talking to anybody. Or if they do talk, they're just angry with them all the time, or they just won't say anything at all. Because if you pick up on depression, a lot of times you can catch things. Or if they start talking about suicidal statements, passive suicidal statements like it'd be better if I didn't wake up, or it'd be better if I just wasn't here. Because they're saying it'd be better if I was dead, but they're not actually saying they're going to harm themselves. That's why you need to have a counselor on your sports medicine team. You need to have a psychologist. You need to have these people you can talk to and say, what do I do for this person? Hopefully you get them to the professional to talk to them. But it's getting outside of your scope now as an athletic trainer. Or even suicidal statements of, I want to harm myself, I'm going to hang myself, whatever it may be, then they need to be taken care of. If you seriously think they are going to harm themselves and you're sure of it, you can call the police. You can always say you protect them from themselves and say this person has had made suicidal statements and they need help. They refuse to get help and they're saying they're going to harm themselves. Allow the other professionals to come in, take care of it, and hopefully protect them from themselves. Most of the time, it doesn't get that severe, but we need to be able to recognize depression before it gets that severe and get them to accept it. Hey, I've got this injury. I can get ACL reconstruction. I can get back out there. It's not the end of my career. Or if it is the end of my career, how else can I stay involved? I can help my teammates by helping coach. I can help that backup quarterback by being able to stand out there and tell him what's going on, be able to pick up what's going on and talk to him when he comes off the sidelines, and explain what I'm seeing and be able to help them. If they can see they can still contribute, they'll accept it a whole lot quicker. So psychological domain, yes, you'll deal with it. Just be able to pick up on things and know they're going to go through these stages. They're not going to hate you forever. It's short term, usually over by the next day or even after the game. They thank you for not letting them continue. They understand at that point that it would have hurt them a whole lot more. Initial treatment of the injuries, usually we use the term RICE. Another acronym, rest, ice, compression, elevation. On most injuries, sprain, strains, contusions, which is a bruise, definitely can use RICE. Now for a fracture, you may not put compression or elevation because we splint it just like we find it. We always splint something, a joint above and a joint below to protect it and refer fracture. But any other time for your sprain, strains, contusions, those types of things, RICE is perfect. The biggest thing is elevation. We don't get swelling out by icing. We reduce or we control the amount that it swells. So we want to rest, we put ice, compression, and elevation. All helps with controlling the amount of swelling that happens. Elevation and compression can help get swelling out. But initially we want to try to keep it from swelling. The biggest thing here, you see this person, the leg is elevated. We always want somebody in the independent position, meaning that it's elevated above the heart. At a dependent position, they may be seated in a chair and the foot on the floor. So if you're sitting somewhere right now and your feet's on the floor, you're in a seated position on your couch or on your chair at your desk, at your computer desk, then your ankle is in the dependent position if it's on the floor, lower than your heart. Anytime we elevate, we put them in an independent position. That's best for the control of swelling. So be very familiar with the term independent position because that's the position you want them in. You always choose an icing method, whether it be ice pack or whatever, to put them in the independent position. Our short-term goals: control swelling, control pain. With control swelling, with control pain, it's going to put us well ahead in our rehab regimen. That'll keep it to where we don't lose all those days trying to get the swelling out. We decrease the pain. The swelling will cause pain, both mechanically and heighten the sense of pain. So, because of the chemical mediators with the swelling. So we really want to focus on the short-term goals of control swelling, control pain. Keep them in that independent position as much as possible. When they go back home or back to the dorm room, don't get in a hot shower because it's going to make it swell up. Keep icing it every couple of hours for 20 minutes, whatever it may be. We'll talk about modalities here in a minute. Rehab goals. Once we get past that initial phase of that short-term goal, it just happened, then we want to make sure we're past the pain and swelling phase. We want to control that, and then we want to increase several things. Range of motion. We have active range of motion. If I do range of motion myself, so I bend my elbow, I do elbow flexion, that is active range of motion. If I'm standing here and you have my arm and I'm relaxed and you push my arm into flexion, that's passive range of motion, meaning someone else besides the patient or the athlete did the range of motion for them. Then we have resistive, so I did range of motion and you try to give me resistance, or I try to lift up a weight. That's resistive range of motion. So we want to make sure we get range of motion back, full range of motion. We call it bilaterally equal range of motion. My right elbow equals my left elbow in range of motion. Second, we want strength, endurance, and power. There are differences in this. Strength is slow speed. That's your bench press. That's your squats. You're not doing anything real explosive. Endurance is you're doing it over a long period of time. Power is, think of your plyometrics, your jump boxes, explosive movements. The linemen, when they come up real quick to engage the defense, if it's an offensive lineman, that's a power move, but they have to have base strength and endurance to keep doing that over and over, and have strength to be able to do it. So we want to increase those. We want to maintain cardiorespiratory fitness. We used to refer to this as cardiovascular fitness. Now we call it cardiorespiratory fitness. We want to keep them in shape. So we got to come up with something to keep them in shape, or else they're going to get out of shape and they're not going to be ready to get back with the team again. The next is proprioception. Proprioception is if you take your left hand and put it behind your head like this, and take your right index finger and touch your left wrist. How did you know where your left wrist was at? That's proprioception. You have sensory receptors in your joints that tell where the joint's at in space without you seeing it. So with my eyes open, if you stand up, keep your eyes open, you have balance and proprioceptive input telling you where you're at in space, where you're standing, how you're standing. If you close your eyes and stand there for a couple minutes, you'll feel yourself start to sway a little bit. You lose the visual balance input and you're relying solely on proprioceptive or sensory input. And we have to retrain proprioceptors. When you sprain an ankle, you injure proprioceptors. If you jump for a rebound, if you don't retrain them, you don't know where your foot's at in space, and you may land and sprain your ankle again. So that's one thing that's overlooked a lot. We talk about it, but we don't always do it. We need to educate the athlete. We need to talk about proper nutrition. If you don't eat correctly, you're not going to heal correctly. We need to talk about proper sleep. If you don't get enough sleep, you're not going to heal correctly. We need to talk about what you need to do for this injury when you're in your dorm room, when you're at home, when you're not with me in the clinic or in the athletic training room. Don't go and take a hot shower. Don't go get in a hot whirlpool, a hot jacuzzi, or any of those steam room, or any of that kind of stuff. Your first 48 to 72 hours, you're going to ice it, you're going to elevate it, and you're going to take it easy. Keep compression on it, whatever it may be. You need to give them instructions on what to do when they're at home, and tell them why they're doing it. So if they understand why they're doing it, they're going to be more compliant. Progressive resistive exercises. Rehab should always be progressive. It should offer resistance. You heal better if you're doing movement. We start range of motion very early in rehab. It used to be they'd cast something and leave it casted for months or even weeks. For an ACL rehab, for ACL reconstruction, somebody blew out their knee. Now we're the very next day, they are actually doing movement and moving that joint to get nutrition in and out of the joint. So early movement and then progressive resistive exercises are very important. So there's a whole class on rehab, devising rehab programs and implementing these programs. But we'll kind of give an overview of joint by joint as we go through it. But these are the main things for this class. We want to control pain and swelling, get range of motion, strength, endurance, and power, maintain fitness, proprioception, training, education, and progressive resistive exercises. This next one, the biggest thing here when doing anything with ice, always remember independent position. Don't forget independent position. Choose a modality that will allow you to elevate whatever it is when you're icing. Modalities. Let's go across this top first. Modality is anything that causes a physiologic response to the body. If we put something on the body, it'll cause a physiologic response. So here, modality can be ice, it can be heat, and many other things we use, ultrasound, electrical components, different things like that. So we'll go through these. Temperature, how hot it should be, time, how long you use it, indication, when you should use it, contraindication, when you should not use it. So ice pack, if I left a K off here, so ice pack or ice cup, 32 degrees. They start melting when you put them on the skin. If it's one you buy that you reuse, then if it's not just plain water that's frozen, then it can get below 32 degrees Fahrenheit. You can give somebody freezer burn, or what we'll call cold injuries. You can freeze the skin, and it's not good. So we may have to put a wet barrier between the two. So wet down a sheet or a pillowcase and put it in a wet pillowcase and put it on the skin then. But ice pack, 20 minutes. We use it on acute injuries. So the injury just happened, compression, elevation, remember that independent position. We don't want to use it contraindicated prior to activity. Ice cup, remember it's 32 degrees. You're moving it because you kind of do a massage at the same time. 10 to 20 minutes depending on how large the area is and how shallow or how deep the area is. Used on acute injuries. And again, don't want to use prior to activities or if they have a cold allergy. Some people can be allergic to ice, so you have to put a barrier between the ice and the skin. Cold whirlpool, 55 to 65 degrees Fahrenheit. Doesn't have to be a whole lot colder than that. Be careful when you first put somebody in for the first time because they can pass out on you. If they have a really warm area, you're putting in a very cold water or cold whirlpool, they can pass out. So kind of be careful that first time in. 20 minutes. Again, acute injury, indication, prior to activity, don't want to use it. With all these colds prior to activity, it's kind of like I before E except after C. For the purpose of this class, don't use it before activity. In other classes, specific things, we'll say it's relative, you can in this instance only. Slush bucket, very similar to cold whirlpool, same temperature, same time, same contraindications and indications. On the cold, always choose what you can elevate. You can put a wrist or an elbow in a slush bucket and have it sitting on a table and the person sitting in a chair, and it's elevated. So choose what you can elevate on an acute injury. Hot pack, always stored in a hydroculator unit. Ones that they're coming, you put in a hydroculator and reuse. It's higher than 170 degrees. That way it kills bacteria on the hot pack itself. It should be put in a terry cloth cover with layers of towels between it and the skin so you don't burn the skin. One thing you want to watch for when using a hot pack or heat in any form of heat is what we call mottling, M-O-T-T-L-I-N-G. Mottling is getting too hot or getting too hot too fast. The skin will have white blotches and not just be red. It should be nice and red looking when you heat or ice it, just a reaction that the skin goes through, normal reaction. 20 minutes, pretty standard. Chronic injuries for an indication in rehab. For rehab, we want to increase blood flow and increase the temperature, increase elasticity, so it stretches better. A lot of people say for warm-up, but it's not really for warm-up, it's for increasing blood flow, increasing elasticity or stretchability of whatever it is, increasing blood flow to that area. We don't want to put heat on acute injury or someone has sensory loss, for example, elderly or very young. Hot whirlpool, 100 to 105 degrees, 120 degrees is scalding. Never need to go much more than 105. 20 minutes, again, same thing, chronic injuries, rehab, increased blood flow to that area. You can move the ankle in a whirlpool and do what we call cryokinetics, so movement with either cold or movement with warm. Movement does, anytime you do movement, causes movement of the muscle, actually does a pumping motion and helps milk swelling out. So that's always one good thing to do at venous return. Don't want it on an acute injury or sensory loss, but don't forget, keep them in the independent position at all times possible. Return to play criteria. And here's the biggies. to be able to go, okay, they've got good strength, they're ready to go back. We always want to use sport-specific drills as rehab once they're advanced. Once we do the basic strengthening and basic things, we want to use sport-specifics. They feel like they're practicing, but we're doing it for rehab. Don't let them develop a bad habit though. Full pain-free range of motion. Let me say that again. Full pain-free range of motion. So I can bend my elbow all the way, elbow flexion, and it's pain-free. Full strength, power, and endurance. When we say full, what means bilaterally equal to the other side. Normal proprioception. I have good balance again. Eyes open and eyes closed. So we have just sensory input. I'm fit. My cardiorespiratory fitness, I'm ready to go back. I like to say they're in better shape than when they came. You have a lot of people, they like to stay in rehab, they like you, they like the staff, but make it hard enough that they're getting tired enough, it's painful for them after a while. It's worse than practice, they're ready to go back to practice, so they're fit. Sport-specific drills, they can run straight away. So for, say, an ankle injury, for instance, they can run straight, they can run backwards, they can do zigzags, they can run and cut, they can jump, two-legged jumps, they can jump from one leg up and down, they can run backwards, they can run figure of eights, they can do all the sport-specific drills they need to do to be able to function in that sport. They need to meet all this criteria before they go back, especially if they're an adolescent. We know with adults, we can give them what our recommendations are, and what they decide to do is their decision, but they've been informed. Informed consent means they understand the pros and cons. Look, you don't have enough strength, you shouldn't be back out there yet. But if they're over 18, we cannot stop them. Only the coach can stop them from going out with the team, yet they can go out on their own and do something if they want to. So our return to play criteria, return to activity criteria should be full pain-free range of motion, full strength, power, and endurance, normal proprioception, cardiorespiratory fitness, sport-specific drills that can do them and can complete